So over to Dr. Amit, who would be talking on the disorders associated with vitreoretinal surgeries, the glaucomas resulting from vitreoretinal surgeries. Over to you.
A very good morning to all. At the outset, I would like to thank AIOC Scientific Committee for giving us the opportunity to present this IC, and I would also like to thank Subhashini ma'am for making me a part of this IC. So I'll be talking about the next 10 minutes about the retinal surgeries which lead to secondary glaucoma. So commonly performed retinal procedures for various retinal diseases are scleral buckling, Pasvana vitrectomy, PPV with combined encircling band, or it can be intravitreal injection of gas salon, or at the end of vitrectomy we can inject gas or inject silicone oil inside the eye. So all these surgeries can lead to short-term elevations of IOP in the immediate post-op period, and also ultimately they can lead to long-term glaucomatous damage if not treated early. So glaucoma in these cases are usually refractory to the conventional therapies. So this one study which is published in 2008, they found that post-vitrectomy glaucoma, almost 14% of all cases of secondary glaucoma were post-vitrectomy glaucoma. So presence of glaucoma in these eyes usually doesn't affect the retinal reattachment, but it will ultimately affect the final visual outcome. So the predisposing factors for glaucoma in these eyes after vitrectomy can be a pre-existing glaucoma, eyes with trauma, myopic eyes, and some of the surgery related is if there is an scleral buckle done, or lensectomy has been done, or following intravitreal gas or silicone oil injection. So what happens in eyes who had already pre-existing glaucoma, in those eyes if PPV is done, IOP is often difficult to control because the surgery-related inflammation and debris decrease the aqueous outflow in the immediate post-op period. And also the optic disc and the retina nerve fiber layer in vitrectomized eyes are most susceptible to damage after the procedure. PPV also alters the intraocular biochemical environment with tendency to reduce the aqueous outflow. So these glaucoma following PPV are one of the most refractory cases of glaucoma. There is associated conjunctival scarring and chronic inflammation following multiple VR surgeries. This leads to difficulty of the traditional filtering surgery, which is often unsuccessful. And also multiple VR procedures can exhaust the RNFL reserves due to transient IOP elevation either during the surgery or sustained IOP elevation in the immediate post-op period. So despite adequate IOP control, glaucoma progression can be observed even during the long-term follow-up in these cases, and control of secondary glaucoma in these eyes after VR surgery may need a larger IOP reduction compared to a normal glaucoma case to prevent evolution of the RNFL loss. So following PPV, glaucoma can be an open-angle glaucoma. It can be because of a pre-existing glaucoma, expansion of the gases, silicone oil overfill. It can be blood-mediated because of associated inflammation, that is trabeculitis, or it can be because of steroid response or mechanical obstruction to the aqueous outflow by the silicone oil, which is emulsified or non-emulsified by fibrin or retained viscoelastic agents. It can be also angle closure glaucoma. Again, it can be a pre-existing angle closure case where you have done a vitrectomy, or it can be because of pupillary block, because of gas, silicone oil, fibrin, or the IOL. It can be a ciliary body edema, which is usually seen following excessive cryo laser, or also during after scleral buckle. We can see that inflammation again can cause annular choroidal detachment and cause angle closure glaucoma. There can be anterior rotation of the ciliary body because of more anteriorly placed scleral buckle. There can be compromised vortex vein drainage because of a tight scleral buckle, and in cases of NVG there can be cases of NVG in PDR CRVO cases, or sometimes in chronic peripheral chronic RD following PPV in the periphery. The RD is persistent, that can cause anterior PVR and neovascular glaucoma. So coming to silicone oil induced glaucoma, is the second most complication of following PPV with silicone oil tamponade after cataract. Prevalence has been seen to be ranging from 2 to almost 56% in various studies, and almost one study which was conducted in 2005, out of all post-vitrectomy patients with glaucoma, silicone oil was found to be the offending agent in almost 73% cases, and most of these cases had the endotamponade for more than 3 months duration. And the silicone oil-induced glaucoma can be early onset or a late onset glaucoma. Early onset glaucoma can be again angle closure because of pupillary block by the migration of silicone oil from the posterior chamber to the anterior chamber. There can be pre-existing synechiae, or immediately after surgery because of inflammation synechiae can form, or it can be an open angle glaucoma because of, in a case of pre-existing open angle glaucoma or inflammation causing trabeculitis, or it can be mechanical blockage of the trabecular meshock by the silicone oil present in the anterior chamber, or also because of a steroid response. So here you can see in this picture that the silicone oil can, if it is overfilled eye, can push the iris lens diaphragm anteriorly and cause an angle closure glaucoma. So some cases like FAK or pseudophakia, when you're doing a vitrectomy, it's always advisable to do a inferior iridectomy, which is also known as endos iridectomy, which allows the silicone oil to fall back into the posterior chamber and can establish a normal aqueous outflow and can reduce the angle closure attack. So when there is a large silicone oil bubble in the immediate post-op period in the anterior chamber, so what can be done? If we can be removed through viscoelastics, but again this viscoelastic technique can cause emulsification of the silicone oil subsequently, and also migration of other silicone oil into the anterior chamber. So what is the best technique is using an AC maintainer with a high infusion rate, and then using another extractor port through the another side port and extracting the silicone oil from the anterior chamber. At the same time, the anterior chamber will be filled up by the air through the infusion cannula, and the anterior chamber will be maintained. There will be no collapse of the anterior chamber during this period, and there will be no migration of silicone oil from the posterior chamber into the anterior chamber. So coming to late onset glaucoma, again the risk of consistently raised IOP is almost 5 times higher than when silicone oil is used compared to when BSS or any gas is used at the end of the surgery. Risk factors are again FAK cases, presence of silicone oil in the anterior chamber at the end of the surgery, emulsification of silicone oil, rubeosis iridis, and presence of peripheral anterior synechiae. The mechanisms of late angle closure glaucoma can be angle closure through PAS or neovascular membranes, or inflammation, or also because of emulsified silicone oil droplets, and additionally there can be direct neurotoxic effect on the optic nerve fibers by silicone oil. So which are the eyes which are at risk of emulsification of silicone oil after the silicone oil is injected? These aphakic eyes, again the eyes with trauma. If there is an underfill of silicone oil, because there will be movement of the silicone oil and it will be mixing with the aqueous more, and then those eyes also at risk of earlier emulsification of the silicone oil. So management of late onset silicone oil induced glaucoma, either silicone oil extraction can be done alone, and success rate is around 45 to 60%. And some studies have the combined silicone oil extraction with glaucoma surgery in the same sitting, but those cases hypotony has been found to be a major cause of failure in these cases. So always it is better to do the silicone oil extraction first, give topical medications. If not controlled, then do a glaucoma surgery if needed. So what are the glaucoma surgeries? Trabeculectomy, as I discussed before, most of the time is more prone for failure because there is less available naive conjunctiva, and presence of emulsified silicone oil can induce inflammation and fibrosis at the level of the trabecular meshock as well as in the subconjunctival space. So best option will be the glaucoma drainage devices. So there are various studies on MF glaucoma bulb in silicone induced glaucoma, where the success rate has been found to be as high as 60 to 80%. So again, there might be some problem with silicone GDD placement in this eyes. So the quadrant which is usually preferred is the infranasal quadrant, and post-operative failure of GDD is again because of migration of silicone oil into the subconjunctival space through the tube. So other options in these cases can be diode laser, as Dr. Shreyash has already mentioned, and then in NVG, which we use, here also it can be used. Then express mini shunt has been used in some early cases, and also GAT has been tried out in various studies. The advantage with this GAT is it can spare the conjunctiva for future GDD or a BLEP procedure. So coming to glaucoma after scleral buccal, incidence is around 1.4 to 4.4%. It is mainly because of impaired venous drainage through the vortex veins. Because of the surgery-related inflammation, there will be congestion and swelling of the ciliary body, and that causes anterior rotation, pushing the lens iris diaphragm forward. Risk factors are again the pre-existing angle closure cases, use of an encircling band, if the band is placed too anteriorly, and if there is post-operative choroidal detachment. So most of these cases do well with the topical medications in the immediate post-op period. Once the inflammation subsides, it can reverse back. So topical corticosteroids, cycloplegics can be given, as Dr. Shayas had mentioned, in inflammatory cases. Echo suppressant should be given. Myotic should be, however, avoided in these cases. So laser therapy, actually laser iodotomy doesn't help in these cases. Laser iodoplasty can be tried. In cases where all these initial measures fail, we have to go for glaucoma drainage procedures. So this certain modification can be done. If already there is a scleral buccal, you can just place the tube below the buccal, which acts as the fibrous capsule around the buccal will act as a reservoir for the aqueous collection. Also some modified techniques of trimming the wings of the verbal bulb can be tried in cases of buccal-induced glaucoma. So again, failure of this GDD occurs because of obstruction of the distal tube by fibrous tissue. The last thing is glaucoma after intravitreal gas injection. So pneumatic retinopexy, the gases used commonly are SF6 and C3F8. They provide a prolonged tamponade as compared to air, which is injected in some cases at the end of vitrectomy. So what you should remember here is the doubling time of these gases. These gases are often expansile gases, and SF6 volume, whatever you are injecting, usually doubles by around 48 hours. And C3F8 doubles by up to 4 times in size, increases by around 72 hours. So this is the time when most of these patients present with increased risk of glaucoma. So risk of IOP elevation after SF6 injection has been found to be as the range from 6 to as high as 67%, and most often seen with when 100% SF6 gas is injected. With C3F8 also the percentage is around 18 to 60%. This mechanism is because the injection of expansile gases into the vitreous cavity can cause anterior displacement of the lens iris diaphragm immediately in the post-op period, which can cause secondary angle closure with or without pupillary glaucoma. And greatest pressure elevation, as I mentioned, is during the period of maximum gas expansion, and the rate of liquid vitreous and aqueous egress cannot keep pace with the increasing gas volume. So that's why these patients present with very high IOP. So how can you prevent? We can use 20% SS6 and 14% C3F8, and also the volume we should not inject more volume. So for pneumatic retinopexy in a non-vitrectomized eye, maximum volume we inject is 0.3 ml. In the vitrectomized eye, 20% up to 4 ml we should inject, and should advise the patients to maintain a face down position. And also high altitude can cause expansion of the bubble. So these patients should be advised not to travel to higher altitude at least 2 weeks after the surgery. So these patients, medical therapy can be tried, laser can be given. So to summarize, PPV in such cases is glaucoma in cases eyes with PPV is a challenge for the ophthalmologist. So based on the mechanism, we have various options to treat. Either do a laser, or if there is a overfill, we can remove the silicone oil immediate post-op, or do silicone oil removal and then observe, and then do a trabeculectomy or GDD if needed in the follow-up time. Thank you.
Thank you, Dr.